So good evening, everyone. Thank you for coming tonight to our session. Hopefully it will be one that will be beneficial. As Nicole's introduced me, I'm Sia. I'm one of the general and obstetric medicine physicians that work at the Mercy and Northern. And I'm the head of medical obstetrics as well at the Northern. This evening, I'll be taking you through Hyperemesis Gravidarum mainly, and there'll also be a brief discourse around the postnatal follow-up of the hypertensive disorders of pregnancy, which includes preeclampsia. My colleague in obstetrics, Ekaterina, will go through that in more detail in her talk, I'm sure. So before we begin, I'd like to acknowledge the traditional owners of the land on which we work in, the Wurundjeri people of the Kulin Nation, and I pay respect to elders past, present, and emerging, and to any Aboriginal persons present here online with us today. So with regards to today's session with myself, like I said, I'll mainly be going through Hyperemesis Gravidarum. It will be looking at how to diagnose it as well as the investigations that go along with it. There'll mainly be a focus on treatments and what patients in this who suffer from Hyperemesis Gravidarum require. And we'll also be talking about the pregnancy and neonatal outcomes as well for Hyperemesis Gravidarum, and as well as the recurrence risk and preconception counseling. I'll very briefly talk about the postnatal follow-up and the importance of postnatal follow-up in patients with preeclampsia and hypertensive disorders of pregnancy. And at the very end, I'll just be briefly summarizing our medical obstetrics at home service through the Northern, which very much caters to these two patient groups. Just wanted to highlight that there is a guideline for Hyperemesis Gravidarum, and that is through the Society of Obstetric Medicine of Australia and New Zealand, and this was released in 2019. It is a very useful guide, although it can be quite lengthy at 67 pages long, but just to flag for your attention that this is available for your use if you need to, and hopefully in your take-home or post-webinar resources, there are tables in terms of treatment algorithms for hyperemesis in your take-home pack, as well as the individualized patient treatment template that is often quite useful for patients who have moderate to severe hyperemesis. So with regards to Hyperemesis Gravidarum, it's really important to differentiate between what we consider in some ways simple nausea and vomiting in pregnancy. That is quite common. And then also Hyperemesis Gravidarum. So nausea and vomiting in pregnancy, or what you might sometimes see in the literature as NVP, is very much nausea, vomiting, and or dry retching that's caused by pregnancy. It's very important to make sure that it's not being caused by other causes, and often the onset is very much accepted to happen in first trimester. There is no single accepted definition of Hyperemesis Gravidarum, but the most widely accepted or widely mentioned definition is that it is very much a persistent vomiting, where again, it's not related to other causes outside of the pregnancy. There's often an objective measure of acute starvation, and that often comes in the form of either carbohydrate deprivation or ketonuria. There are often electrolyte abnormalities and acid-base disturbances, with the most common being hyponatremia, hypokalemia, hypochloremia, and there can be a metabolic alkalosis as well as hypomagnesemia. There is often a bit of weight loss that happens, especially with the moderate to severe Hyperemesis Gravidarum. Again, there's a bit of debate in the literature as to how much weight loss usually occurs, but generally it's accepted to be either 5% or more of the pre-pregnancy weight for the woman. And again, widely accepted that the onset for Hyperemesis Gravidarum usually occurs before 22 weeks gestation. In terms of the incidence and natural history of Hyperemesis Gravidarum, there was a 2017 Australian observational study of about 116 women, and this was done in a single centre of Sydney Metropolitan Maternity Centre. And in that study, about 72% of women reported having nausea, vomiting in pregnancy, with 42% of them being mild, about half of them reporting moderate symptoms, and 1% reporting severe. Hyperemesis gravidarum, thankfully, in terms of incidence, is lower than the nausea, vomiting of pregnancy, but there is a variation in terms of countries, with the most commonly accepted incidence being about 1.1%, and most of the developed countries do report around the same rates as well. In terms of the natural history of hyperemesis gravidarum and nausea, vomiting in pregnancy, there is often an onset between 4 weeks to 10 weeks of gestation, and usually by about 22 weeks, it should resolve or get better. Although there is a meta-analysis that shows that about 24% of them did still have some residual symptoms of nausea and vomiting in later pregnancy. And often in hyperemesis gravidarum, there's unfortunately a persistent symptomatology throughout the pregnancy as well. The cause of hyperemesis gravidarum is very much unknown. There are a lot of theories that posit that it's probably due to the high levels of beta-HCG, and oftentimes it's usually due to certain isoforms of the beta-HCG. And that's very much supported by the fact that we do know that hyperemesis tends to happen in multiple pregnancies and also gestational trophoblastic disease. There does appear to be a genetic predisposition, and there is a genetic consortium of sorts that looks at hyperemesis sufferers. There does look like there is a higher incidence of hyperemesis gravidarum and severe nausea and vomiting in pregnancy in first-degree relatives, with about genetic linkage positing it to be anywhere from 22 to 30%. With regards to hyperemesis severity, and this is, I think, one of the important points in this session is very much the PUC 24 score. And this is the score that's commonly used to actually look at how severe hyperemesis is. And based on the PUC 24 score, it's very much stratified in terms of mild, moderate, and severe hyperemesis. And that then goes on to guide what investigations should be done and how women should be treated. It's very much centered around three main questions. The first question being how often or how long, a woman feels nauseated. The second question being around how many times they've thrown up in the last 24 hours. And the third question being around how many times they've had a retching or dry heave in the last 24 hours. So it's very important to note that this is over a 24-hour time frame. And there's the three questions around nausea, the amount of times they vomit, and also how many times they've retched or dry heave. With a mild PUC score being 4 to 6, a moderate being 7 to 12, and severe being 13 or more. So in terms of investigations, very much the tests that are involved in hyperemesis is looking at excluding other causes for nausea and vomiting in pregnancy. So remembering to exclude gastrointestinal causes, so gastroenteritis, Helicobacter pylori, and peptic ulcer disease would be the main ones. There is some literature that suggests that women with very severe hyperemesis gravidarum have about a 20 to 25% rate of having H. pylori positivity. So it's definitely something that should be looked for in someone who's having severe nausea and vomiting. There are other endocrine or I guess metabolic causes to be looked at, and that would be thyroid diseases, diabetic ketoacidosis, and Addisonian crisis in the right patient groups. Very important as well to look to make sure that it's not a central nervous system that's causing the nausea and vomiting. So oftentimes if women are reporting headaches or visual changes or vertiginous symptoms or other focal neurology, it's really important to make sure that they don't have a raised intracranial pressure or a vestibular disorder. Some drugs we know, such as cannabinoids, can cause nausea and vomiting, and also pregnancy vitamins as well, especially those containing iron, can cause nausea and vomiting. And so often, if you're not sure whether these vitamins are causing or contributing to the nausea in pregnancy, it's often okay to tell the woman to stop the medication and see what happens. In terms of the severity of hyperemesis gravidarum, often the initial assessment is really important. That is really important on clinical examination and investigations to assess how the state of starvation and dehydration a woman can often present in. That would be blood pressures, remembering to take a postural blood pressure to make sure that there's no postural drop, and that would be a sign of dehydration if that were to occur. You can also test test for urinary ketones as well to make sure that they're not ketoniuric. The other investigations that are often performed is a full blood count to make sure they're not anemic from nutritional deficiencies, a liver function test. There's often a mild transaminitis that can happen with hyperemesis gravidarum, especially when it's severe. And we usually say to step up to about 2 to 3 times the upper limit of normal of the range that you're working with. And very much anything that is 4 times the upper limit of normal or above, you really should be looking for a primary liver disease. We also look at, understandably, the electrolytes and creatinine, as well as the magnesium levels of a patient with severe hyperemesis. And as I previously mentioned, you can get low sodium, potassium chloride, and magnesium levels, and there can be a raised creatinine as well if a patient's really dehydrated. In terms of thyroid function tests, often we don't suggest having a thyroid function test unless you are on the moderate to severe hyperemesis gravidarum scale. And that's really because there is an evidence, and there are some studies that suggest that up to about 50% of women with hyperemesis do have mildly suppressed TSH. If there is evidence of suppressed TSH in general, often the advice would be to do a T3 and T4 to assess what their thyroid hormones are doing, as well as a TSH receptor antibody to ensure that this isn't Graves' disease, which is important from a neonatal as well as a maternal space as well. There is also often a recommendation to consider an obstetric ultrasound if there is severe hyperemesis, and that's really to rule out multiple pregnancies as well as trophoblastic disease, which we do know happens, which can contribute to severe hyperemesis. In terms of treatment goals for hyperemesis gravidarum, it's very much centered around 5 tenets, and the 5 main tenets are: 1, to actually reduce the feeling of nausea and vomiting and or dry retching in a woman. The second is centered around reducing the gastric dysmotility that happens in hyperemesis, and so that's really looking to treat with reflux and constipation. The third and fourth tenets is around maintaining hydration and electrolytes, as well as maintaining nutrition. And fifth of all is actually remembering psychosocial support, because it can be a very debilitating time for a woman. With regards to the antiemetics that are used in hyperemesis, often a combination of different agents may be needed. And sometimes what happens is that you may need to, if an agent isn't working, then oftentimes the recommendation is to wean and cease and try another agent. So just to quickly walk you through a table, which is can be quite busy, is that with the treatment for hyperemesis is very much determined by how severe the hyperemesis is, and that's very much dictated by the PUC 24 score. And so it's really important to do that PUC 24 score when you're looking to treat a woman with hyperemesis. So in the mild PUC score group, or the mild hyperemesis group, oftentimes what's tried is the pyridoxine. So that's anywhere from 10 to 50 milligrams of QID. And you can try ginger as well. There is some equivocal evidence as to whether ginger works, and you can get that either in good old regular ginger, or there are ginger tablets as well that exist, and you can go up to about 3 times a day of the ginger tablets essentially. In the moderate hyperemesis group, oftentimes what gets used is antihistamines and prokinetics. So often the first line drug that is used is metoclopramide, 10 milligrams TDS as a maximum dose. The other medications that tend to get used is doxylamine, prochlorperazine, and promethazine. If that does not seem to work, or it's not quite controlling the symptoms as much as you would like it to, you can add on ondansetron up to 3 times a day. In the severe group, it's very much similar to what happens with patients with moderate hyperemesis, but the main difference is that cyclizine is often used as one of the antihistamines, and that can go up to 50 milligrams TDS. It can be quite hard to find in chemists, but there are chemists that stock it, and it usually comes in oral form, and there are IV forms as well that can be used if a woman is just not tolerating any oral agents. Again, ondansetron can be added on. And as the last line, steroids are often used at high doses to try to help with the symptoms of hyperemesis. If the woman can tolerate oral prednisolone, that would be the preferred option. But if they're not tolerating anything at all, then hydrocortisone is often what is used. And when a woman's able to tolerate oral intake, that hydrocortisone is then swapped across to prednisolone. The recommendation is often to wean every week, and you would wean down to the lowest effective dose for a woman. If during the weaning process, a woman feels like the hyperemesis is worsening again, then often the advice is to go back to the dose, go up again to the dose that was working for her, and to try to go out for another week and take it from there. It's really important with treating the nausea and vomiting in hyperemesis that a good way to actually monitor treatment and whether it's working is to actually repeat a puke score a couple of days after the medications are introduced, and to actually have an objective measure to see whether or not the treatments are working before either adding an agent or changing an agent. The main side effects with any of these antiemetics is very much the sedation. And so often women find they get quite sedated when they're on a lot of medications. That can be resolved in some ways by trying to stack the medications at night as opposed to the daytime. And there are some anticholinergic effects as well that can be reported. Rare side effects, but important to note for metoclopramide and prochlorperazine is that women can sometimes have tardive dyskinesia and akathisia. The dyskinesias often happen in chronic use, but it is important to make sure that women are aware that that can happen and to report that if that happens. The other agents that sometimes get used for refractory hyperemesis but have very little evidence in general for is mirtazapine. And there are some small studies that show benefit in reducing the nausea and vomiting, as well as the depressive symptoms that can happen in severe hyperemesis. There are even more limited studies looking at the use of gabapentin, but that again does look like there is some effect on nausea and vomiting. Remembering, however, that recently the TGA has put out a report that there is an increased signal for congenital malformations in first trimester with pregabalin, which is another gabapentinoid. That doesn't seem to translate across to gabapentin at this stage, because the limited studies that we have doesn't suggest that there's congenital malformations in first trimester with gabapentin, but just to acknowledge that they are from the same drug classes, and so we often would be trying other medications before going to gabapentin, and perhaps the place where gabapentin is really once you pass the first trimester, and if a patient's still really having really bad symptoms from hyperemesis. The second tenet of treatment with hyperemesis is really around reducing gastric dysmotility. And there is a known association of gastric dysthymia with severe hyperemesis. Again, the etiology of this is not very clear. Some posit that it is to do with estrogen or progesterone levels that go up in pregnancy. And really the result of reduced gastric dysmotility is to treat reflux and constipation that occurs. In terms of treatment that happens, again, it's very much what medications you use for reflux is very much dependent on how severe the hyperemesis is. If it's just nausea, vomiting, and pregnancy with a bit of mild reflux or mild hyperemesis, then using antacids PRN is usually quite useful, and Gaviscon and Mylanta are often the ones that women end up on because they're easily found at the chemist. With the moderate hyperemesis group, H2 antagonists are usually used, so either ranitidine or famotidine. And then often when they're at the stage of having severe or refractory hyperemesis, proton pump inhibitors are really the preferred choice. And so what would happen is that if a woman's already on a H2 antagonist, by then we would wean and cease it and then start a PPI or proton pump inhibitors. Often the ones that are used are omeprazole, esomeprazole, and pantoprazole. And that's often, you can start it as a daily dose and then go up to BD as needed for the woman. In terms of constipation, that can occur anywhere on the spectrum with people with women who have either mild all the way up to severe hyperemesis. The recommended laxatives are often docacid or Coloxol without the senna component. And that's really not because senna is not safe in pregnancy. Senna is safe in pregnancy. However, it's a stimulant laxative, and so it can cause the abdominal discomfort. And that can be quite troublesome or problematic for women who are already feeling quite nauseated. Movicol is often used as well, and that is safe in pregnancy. In my experience, most women struggle with that mostly from the fluid volume that does come with Movicol, and they just can't stomach the amount of volume that comes with the Movicol. Bisocondyl is also safe in pregnancy. Again, same issues with senna. Being a stimulant laxative can cause abdominal discomfort. And lastly, lactulose can be used as well. Oftentimes, potentially, the very sweet taste of it can set women off or trigger that nausea. So just to be aware of that as well. In terms of trying to maintain hydration and electrolytes, with the oral intake side of things, which is what we encourage in as much as possible, is to try to have small sips of fluid in women. The other things that sometimes women find helpful is having sort of a fizzy drink like a lemonade or soda, and not just plain tap water in some ways. Electrolyte drinks as well, like hydrolyte, can be helpful in terms of trying to maintain the electrolyte balance. There are some women who don't tolerate the drinking component of it well. And so in those cases, sucking on ice cubes or just chewing on them sometimes help as well. So those are some of the other things to consider. Intravenous fluids are very much used in women who have severe hyperemesis gravidarum. Is often used to correct dehydration, but there are some trials emerging now which shows that the actual fluid volume load that happens when it's delivered through the intravenous cannula does seem to actually improve nausea and vomiting in and of itself, separate of the antiemetics when compared to placebo groups in trials. Oftentimes, when intravenous fluids should be administered, we do aim to have it done in an outpatient setting, because understandably, there is a higher patient satisfaction scores compared to if they had to be admitted for days to actually have it administered as an inpatient. Preferred fluids are often Hartmann's or sodium chloride. There's not a lot of evidence to suggest that having dextrose fluids is useful, although it can be entertained if there's concerns around hypoglycemia. And then usually there are additional IV electrolytes that are given depending on what the electrolyte imbalances are. And oftentimes the most common electrolytes that are administered is either IV magnesium or IV potassium. In very severe cases of hyperemesis, oftentimes women come in anywhere from 1 to 2 times a week to get IV fluids. With regards to maintaining nutrition, there's not a lot of evidence around what type of diet is useful for hyperemesis, but oftentimes the advice that we give to women is to eat whatever and whenever. Women often know what foods trigger their nausea and vomiting, and so they often avoid them, and they'll know to identify and avoid them. The advice that we do give women is to try to have small and frequent meals, just to help with that feeling of reflux or that gastric motility that happens. In terms of enteric nutrition versus parenteral nutrition, especially when there's very severe and refractory hyperemesis, the role for NG feeding and TPN is very unclear, and there's not much studies that suggest that having both or one or the other helps a lot. If anything, there does look like there is a reduction in patient satisfaction and an increase in hospital length of stay when both are used. And there's not very strong evidence to suggest that there's any gains in maternal weight or perinatal outcomes when they are used. So oftentimes we steer away from that. They have been given in very severe and refractory cases, but often women these days do get away with oral intake and IV fluids given in the outpatient setting. Bearing in mind the most important vitamins and minerals to replace when someone's having very bad hyperemesis is folate, and 400 micrograms a day and above is the recommended dose, and iodine as well, 150 micrograms a day. As I previously mentioned, sometimes the pregnancy multivitamins that women are on can cause nausea or can contribute to it. So if you're not sure, it's always okay to stop it, especially if they're iron containing, because we know that iron tablets do cause women to feel nauseated. Oftentimes like I said, the most important nutrition or vitamins to replace is the folate and iodine. So it's okay for them to stop the pregnancy multivitamin without there being any major issues to their vitamin and nutrient state. The last thing to remember with treatment for hyperemesis is really the psychosocial support that these women need. Remembering that these women are often young women who are out and about in society, working or being primary caregivers to other children. And so being quite debilitated from constant nausea and vomiting and potentially needing to come in for outpatient IV fluids and things can be a huge adjustment that they need to make in their lives. And so there are a number of studies that have reported an increased depression and anxiety in women with severe hyperemesis and a reduction in quality of life. As healthcare practitioners working with pregnant women, we do need to recognize that adequately treating it and really understanding their concerns is really important when they have severe hyperemesis, because there are studies that suggest that they do have worse mental health outcomes if they do not feel like they're being listened to by their healthcare practitioner. The Edinburgh Depression Scale is often a routine mental health screen for most Australian maternity units, and this is often enough to screen and pick up women who may be at risk of having depression or mental health, essentially suffering from mental health issues with the hyperemesis. Just to flag that there is Hyperemesis Australia, which is very much useful for patients to access. There are support groups that they can access as well if they're feeling really down in their hyperemesis disorder. And often women do find that having other women to talk to about their experience and that lived experience is helpful to try to come up with tips and tricks to get them through their pregnancy. With regards to the pregnancy and neonatal outcomes of hyperemesis, in terms of maternal outcomes, that with the improvement of the IV fluid administration and antiemetics that we've got, that it does appear to have improved over time. And mainly at the moment, the main issues around maternal complications are the nutritional and electrolyte disturbances, the financial impacts that it makes as women have to withdraw from the workforce because of how severe it is, as well as the psychosocial impacts that we've mentioned. With regards to neonatal outcomes, there was a 2011 meta-analysis which looked and saw that there was potentially a bit of an association between severe hyperemesis with low birth weight, but that hasn't really been replicated in other studies. There's also an acknowledgement of a potential association with preterm births, but again, that's really hard to tease out as it wasn't quite clear in a couple of the studies involved in the meta-analysis as to whether or not some of those births were iatrogenic, essentially. With regards to recurrence risk and preconception counseling, the recurrence risk for nausea and vomiting in pregnancy is quite high, and a couple of studies have quoted it in anywhere from the 50 to 83% risk. So it's important to remember and to remind a woman who's hoping to embark on another pregnancy that the risk of having nausea and vomiting again is high, and it's not completely underestimated. The risk of recurrent hyperemesis is a little bit trickier to define, but there are some studies that suggest that it is anywhere from 15 to 26%. There is unfortunately no preventative treatments for hyperemesis, but there is a strong recommendation to have preconception counseling anyway through SOMANS, and that's very much to actually reassure a woman who's hoping to embark on another pregnancy and to give them the information that they need. Because there is that recurrence risk, it's always nice to, for a woman to understand that risk is present, and for them to understand that they need early management and early referral to an obstetrician and or an obstetric medicine physician to try to help manage their hyperemesis as soon as possible. So very briefly now moving into the preeclampsia and hypertensive disorders of pregnancy. And as I've said, the majority of that I think will be covered by my obstetric colleague Ekaterina. I'll just very briefly mention the postnatal impact of these disorders. Recognizing that after delivery, the blood pressure of a woman tends to fall, but then it ends up going up again and it reaches their peak in the 3 to 6 days postpartum period. And that's really important to know as healthcare practitioners, because if you've got a woman who's coming home from hospital, that, you know, with even though their blood pressures are okay at the moment, that they might yet rise and need an increase in their antihypertensives or start antihypertensives at that 3 to 6 day postpartum mark. In the longer term, we do know that there is an increased risk of adverse cardiovascular outcomes, especially with preeclampsia. There's a 2 to 4 times increased risk of having high blood pressure in their lifetime, as well as a 2 times increased risk of heart disease, a 2 times increased risk of diabetes, and a 2 times increased risk of stroke. There is also some emerging evidence that there is about a 2 to 3 times risk of having chronic kidney disease in the future as well. And so all of that speaks to the importance of having annual checkups. And oftentimes that the advice that we give women with hypertensive disorders of pregnancy and preeclampsia is that they do need to have annual surveillance checks with their general practitioner. We talk about reducing their cardiovascular risk factors, so getting them to stop smoking if they're smoking, encouraging exercise, good diet, having a good diet, making sure that they don't gain weight, too much weight, and sort of tip over into the higher BMIs, and also to check on their blood pressures to make sure that they're still normotensive and not hypertensive. The other blood test that we often recommend that they do on an annual basis is a hemoglobin A1C to check that they aren't developing diabetes, and also to check their cholesterol profile, mostly because obviously if they do have a hypercholesterolemia, that increases their risk of having high blood pressures and worse cardiovascular outcomes. With regards to the recurrence risk of preeclampsia and hypertensive disorders of pregnancy, again, the recurrence risk is quoted anywhere from 12 to 38% in the next pregnancy. There is an inverse relation to the onset of preeclampsia. So the younger the gestational age at which they develop hypertension or preeclampsia, then the higher the recurrence risk in the next pregnancy. For the next pregnancy, we do recommend that women start aspirin at 150 milligrams noctae if possible, and we often recommend that that happens before the 16 weeks gestation to reduce the risk of recurrence. So finally, I'd like to briefly talk about the medical obstetrics at home service that runs through the Northern. And this is a service that is run by our midwives as well as the obstetric medicine physicians over at the Northern. It's a combination of a hospital and a home visit and telehealth consults with 2 groups of patients, the first being hyperemesis gravidarum and the second being patients with hypertension and or preeclampsia in pregnancy and also up to 6 weeks postpartum. With the hyperemesis patients, the midwives are able to visit them in their own homes and to give them IV fluids and IV antiemetics, which is really helpful. And often the women that we bring our MOA services to are very grateful because they're often women who are either trying to get to work or they've got other young kids to take care of. And for women with hypertension and preeclampsia in pregnancy and postpartum, we have the ability to lower in blood pressure machines. And often these women are given blood pressure diaries for them to record their blood pressure readings. And we will have a telehealth consult with them to actually assist them with antihypertensive titrations. And we take care of them up to 6 weeks postpartum. The service at the moment runs and delivers the services to the patients in the Northern Health catchment area, and we do this 2 days a week, so the Monday and the Thursday. From the 1st of April, we have got funding and the staffing to go up to 3 days a week, so Monday, Wednesday, Friday. The criteria for being admitted to MOA at the moment is having either hyperemesis gravidarum or hypertension and or preeclampsia, as I've mentioned, but they do need to have come in at least through short stay at the Northern into the emergency department or have had an inpatient admission with us. So just to, especially for those of you who work in the catchment area of the Northern, if you do have patients who meet criteria or you think could benefit from the services, just to remember that there is the service that operates through the Northern. And we'll be happy to try to see whether we can assist with your patient. And those are my reference list, and I will open the floor for questions.
We have one question from Norris. Is mirtazapine safe for administration during pregnancy?
Thanks, Norris. Yes, so it is safe for administration during pregnancy. There's no data to suggest or very strong data to suggest that there's any congenital malformations in the first trimester. There's no risk, there's no reported risk of a preterm birth or a small for gestational age baby as well. The main thing with mirtazapine is to make sure that patients don't get too sedated. We often start with the lowest effective dose. We try to stick to the lowest effective dose, and the dose that we often start off with is 7.5 milligrams nocte.
Nothing else at this stage.
All right. I'm happy to keep answering questions as they pop up. If they pop up as I think Katerina takes on from me, and we'll take it from there. Thank you.
Thank you, Shalva. Lovely talk. So nice. All right. Let me see if I can share my screen now.
Yep. I'm just
So
gonna...
you just need to stop sharing your screen. But
Yep. Sorry. Just gonna...
there we go. I've done it for you.
Oh, great. Thank you.
No worries.
Beautiful. And I just need to share. Let me just give me 2 seconds. Here we go. All right.
Yeah.
Let's come back.
Perfect.
You can see me. Beautiful. And thank you very much for everyone who joining today's session as well. I just want to let you know at the start what Northern Hospital is a level 5 service, and we're really, really keen to do more shared care with our wonderful GP group. So if anyone has any question, please reach out as well. Or visit our website. You'll find under antenatal services a lot of information around it. So my name is Katrina Jovic. I'm a Northern specialist, and I would like to talk on a broad topic, problems in the third trimester. And because, of course, it's a dinner time, I thought I'm going to start with hyperglycemia in pregnancy, or what I call too much sugar. We all know with hyperglycemia, it's a major global health problem, and 1 in 6 births actually occur to women with some degree of hyperglycemia, and majority is related to gestational diabetes, 84%. We all know that diabetes and obesity is significant problem, and it's a problem around the world. So we're seeing tripling of a number over the last 30 years. The biggest concern around the diabetes and obesity, we think it has programming or imprinting effect during the pregnancy. So we think if we actually diagnose and manage this problem well, we might turn the tide of obesity and diabetes for the future. And the idea of this programming is been, I think, around for quite some time. So when you can see the time, start saying how the first 9 months shape your life. Most of our patients will be probably in the right side of the chart. This is a maternal obesity or being overweight, diabetes, excessive weight gain in pregnancy. And there's a Peterson hypothesis that hyperglycemia in pregnancy will be associated with macrosomia. And that will predict future developing of type 2 diabetes and hypertension and impaired glucose tolerance. But actually, if you're on the other side of a chart, if you're malnourished, if you're suffering from chronic medical condition and you're born with low birth weight, there's a different mechanism, which is mostly vasculopathy, will still increase your risk of type 2 diabetes, hypertension, and impaired glucose tolerance in the future, and also renal disease. I should update my graph. Do we know if diabetes is dangerous? Yes, thankfully to the HARPER study, which was published in 2008, is very big observational study, which has included 24,000 women, which were diagnosed with diabetes and just were followed up. And there certainly was increase of babies large for gestational age, primary cesarean section numbers, clinical neonatal hypoglycemia was significantly higher in this group. But what's interesting about HARPER study, which was all about pregnancy pre-programming, that they did lovely follow-up studies in 10 and 14 years' time. One was looking at the children and childhood glucose metabolism, and they certainly proved that the babies who were born with mom who had diabetes had a higher risk of type 2 diabetes or impaired glucose tolerance in childhood. And same outcome for adiposity. So there was increased adiposity as well. So we know what diabetes is bad, and I guess being a GP, we always think about can we actually prevent gestational diabetes? And obviously the thinking would be around can we implement the changes that we actually do for patients who already have a diabetes? And one of the things is a physical activity and exercise. So there's quite a few studies were done, and one of them, there was a Cochrane review, and they did say there was no clear effect on preventing diabetes. And then quite a big randomized control study say, look, doesn't really reduce risk of healthy pregnant women developing diabetes, but potentially reduces maternal weight gain and risk of cesarean section and large for gestational age. So maybe. Other question was, should we just put all our women on low glycemic diet even before diagnosing the diabetes, or what we call dietary intervention? And there was a few systemic reviews and randomized controlled trials, and some of them showed, again, maybe reduction in large for gestational age, but was not very effective in reducing the incidence of diabetes. So we still have a question mark around this one. And then, of course, there were studies looking in combined intervention on combining dietary changes and physical activities, and there's multiple randomized controlled trials, and again, there's inconsistent results. So what do we advise, or what is the current evidence-based recommendation? So we advise women with physical activities and healthy eating during pregnancy will help to reduce excessive weight gain in pregnancy, but it doesn't directly appear to reduce risk of diabetes in pregnancy. We still would like them to use some of this intervention. I put the diagnosis in, and it's all come from Australian Diabetes in Pregnancy Society. You all know what we recommend: glucose tolerance test between 24 and 28 weeks of gestation. But I just more as a reminder, we only need one abnormal reading to diagnose gestational diabetes. But remember, we might pick up women who has a diabetes mellitus in pregnancy. So if you're fasting above 7 or you're too early above 11.1, this is actually suggestive of pre-existing diabetes. We really would like to see this woman early in our clinic. And again, is anyone actually deserves to have an early testing? And yes, we come up with a moderate risk factors and a high risk factor. And the moderate risk factor come from our ethnicity and a highish BMI group between 25 and 35. And a high risk factor will be anyone who has a previous diabetes, anyone who has an elevated blood glucose level, maternal age above 40, family history of diabetes, and I always tell my medical student, everyone has a granny with diabetes, but we're talking about the first degree relatives. Polycystic ovarian syndrome, and sometimes you might have a patient who taking corticosteroids or antipsychotics. They are forgotten group. So 2 moderate risk factors or 1 high risk factors means we should aim to do early GTT. With other testing, so often we'll be asked about question, what about HbA1c, especially in the COVID time? We use it quite a bit. We know what 6.5 will be diagnostic for diabetes outside the pregnancy, but we know what gestational diabetes, based on the DIPS criteria, has much kind of a lower targets. So is HbA1c 5.9 is abnormal? And there is a little bit of a recommendation from New Zealand group who use HbA1c more. They did the study over 16,000 women, and there was association with adverse pregnancy outcome with HbA1c above 5.9. And I always say in a high-risk group, I will consider 2-week basal monitoring, which is totally we can organize. You're familiar with National Diabetes Services Scheme. It's an amazing resource. Patients need to be registered. It's a very quick process. Often they get registered while you're still having conversation with them. There is certainly benefits while they're pregnant. For example, they can pick up glucometer from a local chemist. They will have discount for the testing strips. They will have some educational resources as well. And if they need insulin, they will have a free insulin needles in the future. But also benefits continue after pregnancy. They will be sending them reminders because we do know that there's a high risk of developing type 2 diabetes. And there's also like interactive online platform for the patient. So it's reminding about the healthy eating, exercise, and there's like discussion and support group for the people who going through the diabetes and after. And also there's a benefit for us because we have all our numbers from NDS about how many patients was diagnosed with diabetes, how many of them required insulin. So that's great. In terms of evidence for treatment for diabetes, because it's a great question, do we treat or we don't treat? We know it's poor outcome, and all our evidence kind of come from these 2 big milestone trials, one of them known as Our Choice and was published in 2005. And they actually say, yeah, if you treat the diabetes, you will reduce your risk of poor outcome from 4% to 1%, and number need to treat is 34. And the London study showed quite a similar results as well. The only thing you probably noticed that they have a slightly different targets. So Our Choice study looked at fasting 5.5 and postprandial after 7, and a bit tighter in the London study. So we still have a bit of discussion across multiple services in Victoria, what's actually the target for treatment. And we recognize it, that there might be different targets. And sometimes your patient might come in from Mercy Hospital and say, actually, I'm not on insulin and my fasting is 5.2. However, if they're Northern, we will start them on insulin. We don't know what's the right target, but we allowed this difference between different sites. We know what about 40% people who diagnosed with gestational diabetes will require treatment. And the commonest treatment you will see is the insulin, and use different type, Novorapid, Humalog, Protofen, or Opticillin. They're all safe to use in pregnancy, and usually we initiate it when we see 3 high readings in 1 week, whether it's a 3 high fasting or 3 high postprandial. And all patients is well educated about giving a call to their diabetic educator. And we also educate them how to self-titrate insulin once they started, because we really believe that diabetes is everyone's personal journey. I often have questions about metformin and whether it's safe and whether we use the metformin. We do use metformin. We know it crosses placenta. It's safe, but the main reason why metformin is really our first line is because it's based on our MIG trial, which looked at safety, but also looked at effectiveness. And they showed what about 40% of people who were on metformin were required still additional insulin. So that's why it's really our first choice. But the good thing about MIG trial, again, they follow up their babies at 2 years and then follow them up at 7 to 9 years as well. And they noticed there was a slightly increased adiposity and body mass index of babies who moms were on metformin. But then they also noticed that most of these babies were coming from Auckland group, so who mums originally were on a higher side as well. So that's a question whether it's a metformin or again pre-programming based on maternal condition. So I thought I'd put a few words around treating GDM, which we diagnose early in pregnancy. Remember, I talk about people who say, well, what if to diagnose and what if to run gestational diabetes in early pregnancy? And the latest trial we have is a Toboggan trial. And they look at about 400 women, and it's quite interesting. So basically what they did, they randomized them to immediate treatment and then the delayed treatment until they have repeated test at 24 to 28 weeks and start treatment at that time. Or if they were negative, and it was interesting, 33% who tested originally positive were negative on repeated test and were not treated. But they did say that immediate treatment or earlier treatment of diabetes was associated with reduced risk of adverse neonatal outcome by about 18%. And the number needed to treat was 18, sorry. It's interesting again, it showed the main reduction was around respiratory distress. But there was no difference in, for example, maternal developing hypertension or neonatal lean body mass or timing of delivery. So even though the authors concluded that it's definitely beneficial, but I had a feeling that they might wanted to see more benefits than what the study showed. Every time we talk about the diagnosis of diabetes, is a little bit like a breaking bad news. So most people, when they've been taught they have a gestational diabetes, feel confused. They're obviously concerned about the diagnosis. Often they don't understand why, because not all women have obesity or risk factors for diabetes. Anxious, and they're very rarely positive. And I think that counseling around the diagnosis is all about reassurance, discussing how many resources are available, but there's much more monitoring in place for this patient, and we certainly can improve outcome if we get on top of this condition. And in fact, we also can reduce the type 2 diabetes for this woman in the future. So we do like to think about this positively. In terms of monitoring and delivery, every woman who has a gestational diabetes will have a book with glycemic targets at the front of their book. And as I say, it depends on the services they attend. At Northern Hospital, we're a bit tighter. So we're looking at the fasting less than 5 and postprandial less than 6.7. With gestational diabetes diet and control, we would like to think about it as almost low-risk pregnancy. Some clinicians will consider to order ultrasound at 36 weeks, and often with a good control, we allow pregnancy to go to post dates. However, with gestational diabetes on insulin, we're a little bit more tighter. We like to organize the growth ultrasounds, and often we start in our third trimester, which will be 28, 32, and 36 weeks. And with a good control and no other risk factors, we're looking at having baby between 39 and 40 weeks. And with full control, macrosomia, needing large amount of insulin, or if we have other risk factors, we're looking at earlier term delivery, which is 38 to 39 weeks. One thing which we agree on is the mode of delivery. If the predicted weight is above 4.5 kilogram, there's enough evidence to say what we should consider to offer cesarean section to reduce risk of a shoulder dystocia. We're also well aware what we need to perform 443 cesarean section to prevent one permanent brachial plexus injury. So, and that's what we will normally discuss with our patients when we think about the time and mode of delivery. And I like this one. And now what? Once we had a baby, most of our patients will be discharged with a sleep for glucose tolerance test and 6 to 12 weeks postpartum. We know there's a 30% risk of gestational diabetes in a future pregnancy, and there's a risk of developing of type 2 diabetes. And we say between 1.5 to 10% per year, you will expect a woman to come back with type 2 diabetes. Women who think about future pregnancy, we say yearly glucose tolerance is a good option. People who don't plan a future pregnancy, we divide them in two groups. The high risk, we recommend 3 yearly glucose tolerance. Low risk, recommended fasting BSL and HbA1c every 1 to 2 years. And again, it's based on current ADIPS recommendation. And of course, linked to the diabetes come macrosomia, or large for gestational age. The biggest concern about this diagnosis is that there's no standard definition for large for gestational age. Traditionally, it was considered to be more than 90th centile. However, we kind of move our range, and most of us move towards the 95 centile. And some people go even above 95 centile, which will be 5 kilogram predicted weight at term. also thing to remember, what we are much better at picking up smaller babies than picking up bigger babies. And of course, being a big, being LGA carries the risk. And main concern we get is around the shoulder dystocia. And in fact, if you weigh between 4.5 and 4.7 kilogram, risk of shoulder dystocia is 14%. And today I had a patient in my clinic. She was 4.7 kilogram at 36 weeks. So I could actually tell her what the risk of a shoulder dystocia in her case will be about 21%. There's 50% chance if this patient will need a mid-cavity delivery, and a high risk of brachial plexus injury, and there's quite high risk of being severe and permanent. And other thing about counseling around this woman, there's much higher chance that they're needing an instrumental birth, especially if predicted birth weight above 4.5 kilogram, and there's a high chance of needing a cesarean section, about 45% again, if we're predicting for more than 4.5 kilogram. And of course, there's more chance of a tears and a bleeding for the mum as well. And again, thinking about, can we prevent large for gestational age baby? And if you think about primary prevention, can we stop pregnant women being obese? And is the bariatric surgery is an answer? And there was a nice Sweden study in 2015, which looked at outcome of pregnancy after bariatric surgery. And there certainly was some positive finding. There was a reduction in gestational diabetes. There was significant reduction in LGA, slightly shorter gestational age, but still term. But there was significant increase for small for gestational age, and also increased perinatal mortality. So the answer was actually no. And that's why we actually recommend a break after bariatric surgery at least 12 to 18 months before conception. Other primary prevention is a discussion with women about the weight gain. And I'll always remind our women about the weight gain. The beauty about being a public obstetrician, that's okay to weigh your woman at every visit and talk about the weight gain as well. And just a reminder, if the woman above BMI above 30, the actual weight gain is about 200 grams a week. So we really would like them to put as less as possible, and it's healthy. Secondary prevention, can we prevent by actually picking up our big baby as well? Oh, well, fundal height measurement will pick up about 1/3 of our big babies. Ultrasound often will be challenging, and we always allow about 10 to 15% of mistake. And we say we have about 50% detection rate of birth weight above 4 kilograms. So we're not great at really picking them up. What to do? Do we do cesarean section, or we induce them earlier? Look, in terms of a cesarean section, we would recommend elective cesarean section if we're predicting a weight of 4.5 kilogram in diabetic woman, or more than 5 kilogram woman without diabetes. There is quite a bit of evidence around couple randomized trials, which took a long time to complete, that induction of labor at 39 weeks for a macrosomic baby will reduce poor neonatal outcome. Saying this hasn't been embraced fully, so most hospitals don't have guidelines around timing of induction for macrosomia. However, it goes on a personal discussion. And of course, it comes to this other side, which is a small for gestational age. And Sue Walker has a wonderful talk around it. And she has this powerful saying, if you're born small, you keep dying all your life. So it kind of refers to the start of a conversation about genetic imprinting and increasing risk of vasculopathy and having problems in the future. But our biggest problem is what small for gestational age babies has a 3-4 time-fold increased stillbirth. And it's a really lovely graph on the side. It shows what the black area, which is your average or appropriate for gestational age babies, you could see there's all this background risk for the stillbirth. However, it kind of increases after 39 weeks. And this graph but in red shows small for gestational age, so much higher risk of dying before term and significantly increased risk after 37 weeks. So we know what over the half of the 3 million stillbirths every year are growth restricted. And we do know if we pick up our babies, we probably will improve the outcome and reduce risk of stillbirth. However, 75% of our small babies remain undetected before birth. Just a little bit around the terminology, because we keep using the fetal growth restriction, small for gestational age, and might be a little bit confusing. So some, but not all, growth restricted baby will be small for gestational age. Basically, growth restriction implies that there is a pathological restriction to a potentially bigger baby. And generally speaking, likelihood of fetal growth restriction will be higher if you have a severely small baby. So anyone who falls under 5th centile, you will have a question mark and thinking, maybe it's a fetal growth restriction. But to differentiate it is all about the accurate measurements and a functional assessment. So that's where our ultrasound with amniotic fluid index measurements, Dopplers, and a CTG come into play. This is my favorite question to the medical student. Now let's ask them, how accurate is the measuring tape? Not very accurate, about 20%, and in obese women is about 13%. However, we do say if we plot it on the chart, and especially if it's done by the same person, and it's perfectly feasible in a shared care practice, then it's become more sensitive. And as a reminder, if you think your fetal symphysis fundal height is more or less by 3 centimeters from the gestational age in weeks, or if it's plateau across your measurements, you would like to organize the growth ultrasound. And also keeping in mind of what is the major risk factors for the small for gestational age and the minor risk factors. The major one is your advanced maternal age, smoking, illicit drug, all the chronic disease, the diabetes, the hypertension, the renal impairment, if the woman has a previous small for gestational age or stillbirth. And a minor one would be nulliparity, high BMI, IVF, smoking, but less amount of cigarettes, smaller pregnancy interval or large pregnancy interval, and a history of preeclampsia. There's obviously placental factors as well. Things like recurrent bleeding in pregnancy is concerning, non-uterine abnormality will be concerning, and fetal factors. They're usually in a high-risk care if we know about aneuploidy or genetic syndrome, or there's a congenital infection. We say when we screen for fetal growth restriction, we basically assess every visit, is there any new risk factors emerging? We would like to date our pregnancy accurately, and just to remind, the most important for accurate dating is your ultrasound between 8 and 13 weeks. And we like to address modifiable factors. So we talk about quitting smoking, we never stop. We talk about healthy weight gain, and we would like to treat and control all our medical condition. If you find one major factor or you find multiple minor factors, it's a good idea to organize the growth scan. And often we start in the 3rd trimester, 28, 32, 36. And I thought I will say a few words about preeclampsia just because my topic is quite large. Just to remind you, preeclampsia is common, 5 to 8% of pregnancy, but luckily preterm preeclampsia not that frequently seen, only 0.5% of our pregnancy. And we're looking at the systolic blood pressure of about 140 or equal 140 and diastolic above 90 or equal 90. You only need one of these numbers elevated, but they need to be reproducible on repeated reading in about several hours apart. With preeclampsia, just again as a reminder, because it's a systemic disease, we would like to see involvement of one other organ or one other system or a fetus. So in the past, everyone thought about preeclampsia as a high blood pressure and proteinuria. Yes, it is a preeclampsia, but proteinuria is not mandatory to make a diagnosis. If you have a patient with high blood pressure and fetal growth restriction, it is a preeclampsia. If blood pressure of a patient is 170 above 110, this is a severe hypertension and we need urgent treatment. This woman needs urgent transfer to the hospital, closest hospital. And hopefully you can offer some antihypertensive treatment on the spot, and we will see them immediately as well. What is new around the preeclampsia? And you might see us ordering tests called PERD, which is a preeclampsia ratio test. The specialist or obstetric medicine specialist can offer it. It's not available for GP. But I will explain a little bit what is this test about. The timing is between 20 to 36 weeks. And indication is for women who we consider to be high risk of a preeclampsia. If we have a suspicious features, but not yet confirmed preeclampsia, it's also help us to manage and plan among women who has already diagnosed of preeclampsia. And we also can rule out the other condition, because sometimes we see the patient, for example, with lupus nephritis, they might already have a proteinuria, or diabetic nephropathy, or chronic hypertension with migraines. So they really are helpful. This test is really helpful to decide. So the PERD test been studied in one of the recent studies called Prognosis, and it actually has a very good negative predictive value. So if your PERD result is less than 38, it rules out preeclampsia within 1 week in 99.3% cases, and within 4 weeks in 94. And also it shows like a little table of how we read it. You don't want to be in a red graph, because it means you need a very close surveillance and likely delivery in next 48 hours. And again, we talk a little bit about aspirin. We never stop talking about it, I think. So we do say that aspirin started before 15 or 16 weeks can prevent preterm preeclampsia. And reduction is about 60% from baseline. And it's interesting because Cochrane review looked with, yes, we do like 150, or we do say 150 is what we recommend. However, when you look at the reviews, a lot of studies which were included in this review actually were giving 100 milligrams of aspirin and had a similar effect. So if your patient on 100, don't panic. Unfortunately, aspirin can't prevent term preeclampsia, only preterm one. And unfortunately, aspirin can't prevent fetal growth restriction unless it's related or result of preterm preeclampsia. And the last few words is about the fetal movements. We all would like to raise awareness around it. We do have quite a few studies to look if the awareness of fetal movements will improve the pregnancy outcome. But unfortunately, there was no statistically significant reduction in a stillbirth. However, there's a little bit of increase of intervention was seen, but still there was some trend in reduction of small for gestational age babies. So maybe some benefit, but we still always encourage women to present if there's a reduced fetal movements. And sometimes women forget what we tell them, and they come to your practice instead of coming to maternity assessment center. And I always say you encourage the presentation, you auscultate for fetal heart to reassure that it's ongoing pregnancy. You would like to take a history because you would like to see if there's any possibility or any risk factors for stillbirth or fetal growth restriction. You reassure a woman it's a common presentation, but you would like to refer her to on the same day to maternity assessment center, because we still would like to do the CTG for this woman. And I put some useful contacts for Northern Health in case you want to send us urgent test, or you're concerned about result which come to your practice, or you're seeing patient and you need advice. There's all numbers will be there. And I'll just want to ask if there's any questions.
Nothing at this stage.
Nothing at this stage. And that's okay. I think it's a dinner time as well. It's hard to stay focused.
Was that all from yourself, Ekaterina?
Yes, this is it.
Amazing. So Crystal will just take over now, and I'll just stop sharing your screen. Amazing, Crystal. Ready when you are.
Just give me just one
Take your
moment.
time.
My apologies. How are we doing there? Are we good there?
Yep, perfect.
Yep, fantastic. Hi, everyone. Sorry about that delay there. My name's Crystal Barbato. I'm a program specialist at Health Pathways Melbourne. I have a background as a registered nurse and last 10 years in general practice. So I can assure you I understand the challenges of staying current with the ever-evolving healthcare landscapes. I understand your time's precious and it is the end of the evening and we all wish to log off. So hopefully I can do a quick demonstration of how health pathways can be a fantastic resource at the point of care with your patients. Health Pathways Melbourne is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne primary healthcare networks in partnership with healthcare professionals and organisations in the Melbourne region. Health Pathways provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. Through this, I will demonstrate how to navigate health pathways to find the relevant pathway on common conditions for third trimester of pregnancy. Focusing this time, we're going to look at nausea and vomiting in pregnancy. Okay. All right. So navigating health pathways for nausea and vomiting in pregnancy. Visit the Health Pathways website and log on. Here you can see the landing page where you can see the latest updates and the latest pathway updates. You can search for the user search bar located at the top of the page to enter relevant keywords like pregnancy or nausea. Alternatively, you can use the table of contents on the left-hand side of the page. Select the pathway that's relevant. And here we are in nausea and vomiting in pregnancy. The assessment section is a concise list of steps that users may consider using to diagnose and evaluate the severity of a patient at the point of care. Drop boxes throughout provide additional information such as risk factors, and perform examinations. Moving further down the page, we've got the management section, which is a succinct list of steps that clinicians may consider taking and includes additional information needed to execute these steps, such as consider non-pharmacological options and pharmacological options. So we continue down that pathway. We'll get to the referral section. This section is what we love at Health Pathways. It includes locally relevant requests and referrals that the clinician might request from a third party for their patients. We can show that here with a link to acute obstetric assessment. Clicking on this one has taken us out to the referral page, which is acute obstetric referral or admission same day. On this page, we have a clinical editor's note, which is a brief temporary note added by a clinician about a development in the wider health system or community that may affect how a clinician assesses or manages their patient. That one there was showing, identifying the VVED. As we go down, this referral pathway, you'll see, provides information on relevant private and public. As we navigate down to the public section, you'll be able to see the relevant referral criteria, which includes a list of the statewide referral criteria. Drop boxes, of course, again, provide additional information that the physician may require. As we go down further, I've dropped down here the Eastern Melbourne. So here we've actually got our local providers. And there you can see we've got Northern Health. Returning back to our main pathway, at the bottom of every page, we have the information section. This provides a list of resources for health professionals and for patients that have been chosen as particularly useful at the point of contact. Here I've just popped together a list of relevant pathways. As you can see on antenatal care, and on to the next slide, we have a few more as well, including our specific obstetric referrals. Thank you, everyone. So Health Pathways is available to general practice teams and other clinicians in the Eastern Melbourne PHN and Northwestern Melbourne PHN catchments. To access Health Pathways, just go to the website, melbourne.healthpathways.org.au to log in. If you don't have access yet, you can click on register, which brings up an online form, and we can also organise automatic login for you to access. And that brings me to the end. So thank you so much, everybody. And hopefully you found that helpful.
Thank you so much for sharing that, Crystal. I'd now like to open up this session to any questions that you may have for Crystal or any of the other presenters. I'll just leave it for just a moment so you can type your questions. I know Katerina has answered some in the chat already, which is great. But I'll just wait a moment before I close it off.
Hi everyone. This is Arzu here. I'm the head of obstetrics at Northern, and I just want to, while we are still looking at the questions and the answer session, I just want to thank all the speakers and the Eastern PHN to actually organizing this. So thank you so much. I'll turn on my video as well. Sorry, this is. That's fine. Don't worry about it. My Zoom has been playing up a lot. So I was just saying that thank you so much for organizing this, and also all the attendees for attending these series of sessions that we are doing for women's health and the children's as well. This is the second session, and we're going to do one for gynae and another one for peds, I presume. And I would love to get your feedback, all the attendees. That will help us establishing our future sessions as well. And also we'll get to know the needs of our community and our GPs in terms of education-wise or in terms of any support that you do need from the hospital. Just really recapping a couple of things. We are level 5 maternity services. If you don't know, we have got ICU, we have got CCU, and we've got a very, very, very dedicated medical obstetrics unit. So we work together in a really close relationship with our pediatric team, with our neonatology team, and our medical obstetrics. We don't have neonatal ICU in future, hopefully. Yes, this is what our plan is in future. However, I would be really looking forward for your feedback in future about these sessions. Sorry, I won't really take too much of your time, but thanks everyone. Thanks for attending and thanks for organizing.
Thank you so much for your thank yous. I believe there is one question that's come up.
Yes, that was a question, whether you repeat test at 28 weeks if your early glucose tolerance is negative. Yeah, absolutely, you would repeat the test. The whole idea of early testing is your high-risk women. So you're looking for these who developed that early or had a pre-existing diabetes, while the 28 weeks is the commonest time when most people will develop gestational diabetes. So yes, if it's negative early, it's great news, but please repeat it again between 24 to 28 weeks.
Thank you so much for that response. Now, if that is all, and there are no further questions, I might share my screen. And I'd like to thank you all for being a part of tonight's session. It has been an absolute pleasure to have you all here. I hope you've taken away some valuable insights. I'd also like to extend a special thank you to our exceptional presenters for their fabulous work. By participating in tonight's RACGP accredited activity, you'll receive 2 hours in educational activities, and I will lodge those hours through the RACGP on your behalf. At the end of this session, a link to the workshop survey will appear on your screen. Please do take a moment to fill in the event survey for your accreditation and to provide valuable feedback so that we can further improve these education sessions. Your responses are greatly appreciated. Please also take a moment to check out other upcoming infant education events by scanning the other QR code on your screen. It will take you directly to our events page on the infant website where you'll be able to find out more information about what's coming up and you'll be able to register yourself for one. There will be a follow-up email that everyone will receive, which will include a copy of the presentations you've seen tonight, in addition to other relevant resources and a link to this webinar. You will also receive a certificate within the next 4 weeks of this session from infant. And on that note, I'd like to thank you all for your time and attention this evening. That is all from us, and enjoy the rest of your night. Thank you all.